Thank you very much for inviting me here today. It's indeed a privilege, and I can tell you something. Pretty much most of this program was designed with consultation from friends and colleagues who worked in HIV. So in fact, when I first talked about Program Rose, Prof. Adiba told me, if we are sorting out HIV, HPV and cervical cancer should be a walk in the park. So I'm not going to talk about a test because we know that dealing with any diseases is beyond a test. This is really a program. And just to set the scene, in terms of the burden of disease, we know that a woman dies from cervical cancer every 2 minutes. And because this is a HIV meeting, what I wanted to do was just set the scene before I gave my talk.
Imagine the most important woman in your life dying from a cancer that is totally preventable.
Yeah, it's had an impact on a lot of my life.
My mother cried for me and she said, my daughter needs to be saved.
The worst day of my life.
It's the second most common cancer.
And we just keep on fighting, yeah.
Lives are at stake. The question is, how's the world going to step up to meet that need?
And we have to do something.
We're going to travel the globe and discover how the world can rise up to the elimination of cervical cancer.
We know what causes it, we know how to screen for it, we know how to treat for it.
We have the weapon to prevent this from happening.
We have a vaccine.
We've used self-sampling.
Cervical cancer is more prevalent in disadvantaged populations.
We have to think multi-generational.
Getting to the end game is a matter of political will.
We cannot waste a second longer.
Oh, stand beside me.
Impact it has like the family that you leave behind.
Oh, stand your
We have the tools. We call on governments to implement them with full commitment.
And really encourage every country to adopt elimination targets.
Nothing's gonna stop us believing.
It's so powerful.
We are all moving toward this goal.
Australia is on track to be the first country in the world to eliminate cervical cancer.
This is a story about rising up, about how human ambition can overcome the seemingly impossible.
We have the opportunity.
It can be done.
I'll be there to protect you.
Every time I watch this video, it's very sobering because we no longer need science to invent vaccines. We've already heard from 3 doses, now 1 dose is sufficient. From Pap smears annually, we now have HPV testing that can be given as few as twice in a lifetime. And the treatment have become simpler from excision to thermal ablation. No other cancer has been so easy, eliminatable with less and less interventions. So we now look at this as a social impact of how we can make a difference. So we always talk about equity, and this is a cancer that is a disease of inequity. When we look at countries, we need to look at how we can convert these cubes into circles for disadvantaged countries. And from where I come from, a country of 33 million, most of our population is covered by a national health service with an increasing out-of-pocket healthcare expense population. This, I think, is very similar to many low and middle income countries. So we have a situation where we're in the same boat together. But even in Malaysia, there is difference in population. So I believe not one country will come up with or will utilize just one solution. We have to serve the disadvantaged even in very high income countries. So with this came the birth of Program ROSE. ROSE stands for Removing Obstacles to Cervical Cancer. It was really designed in Malaysia to deal with the disadvantaged women who have no access to screening. And as I said, I took many pages out of the HIV books in dealing with whether it's communication, advocacy, screening, and follow-up. So essentially, the summary of ROSE is that as a test, I can go anywhere to screen any woman with a swab and with my mobile phone. That's the test. But behind every test, there's a lot of other issues that we have to deal with. So it is a community screening tool that removes the need for a woman to attend a clinic to be screened. It permits health surveillance because the back end of this health mobile technology is a screening registry that allows us to follow up women and to communicate with them. So the innovation behind ROSE was really using the design thinking. We really wanted to ensure that we had a solution that was acceptable to both women and the healthcare providers, and it must be evolving and agile. We saw the program changed during the COVID pandemic in that much of the education happened during using Zoom. We educated women using Zoom, we delivered swabs to them, so the screening still carried on during the COVID pandemic. And this is a really nice illustration of how Program ROSE was actually designed not using healthcare professionals predominantly. We used many different expertise, such as people from the banking experts, program designers, computer program designers, lawyers, because everyone brought to them a different perspective. And it was using this concept that we got together to come up with an idea that suited the Malaysian population using a sort of a design thinking methodology. And so Program ROSE started as a pilot program back in 2017. And when it ended as a pilot research study, we felt that we couldn't just stop there because the acceptability was so good. And so it became a program. We then started a foundation to deliver the program. We built a laboratory with good facilities so that the women could get the best possible test. And to date, we have more than 29,000 women screened. So what we wanted to do was this. We know that if we follow lots of policies, we create something that's shining, the women themselves may not use what we think is good for them. So through constant design and revisiting what we did, we created something that the women themselves found acceptable and the healthcare professionals found acceptable. And we charted what would a woman need to go through when they undergo screening to the point where they need treatment. What are the entrances they need to make when they go to a hospital visit? What are the financial implications? Really charting out step by step what they needed to do. So it was really conceptualized, even starting with the journey of one single woman. And if you look at the emblem of ROSE, even the emblem of when we designed the logo, I don't know whether some of you see it. It's actually the woman's mom. Yes, the mother's arm carrying a child, because what we wanted to do was to protect mothers, because they are the foundation of society. If you protect them, you keep them from cancer, they will bring on the next generation and their education, everything else. So mothers were very important to it was the heart of the program, women. And the design of the mobile technology, the front end, was such that it was simple. As an academician and scientist, I wanted to put many, many fields in it. Smoking, contraceptive use, BMI, everything. But the computer programmer told me, no, don't do that. If you want to create something simple for healthcare professionals to use, for the general public to use, and to make sure that you can scale up screening, make sure it's something very simple. Don't be tempted to put red cap onto a phone. I said, okay. So Program ROSE, as it stands, isn't just a test. We have 5 pillars. And many of these pillars that I want to talk about, really I've learned from your community and what you've done for HIV. It starts with education and advocacy, self-sampling, PCR testing, digital health platform, and linkage of care. So our mission as a foundation, I had to create a foundation because we could not deliver the services through a university. This was a program that we wanted to reach the underserved population. So we created a foundation to deliver program roles to Malaysian women. In terms of education and advocacy, this was done to raise awareness because it's a real paradigm shift. We shifted from pap smears using a speculum to a swab like this. And so trust was very difficult to gain even from healthcare professionals. And COVID was sort of the silver lining for us because after COVID, everyone knew about a swab. Everyone knew about PCR. So they understood about the test. And so we spend quite a significant amount of our time educating and advocating. But just like dealing with HIV, we are still trying to address perceptions and stigma. And Pui helped us with this. We adapted an HIV questionnaire to look at doctors' perspective in terms of HPV. So we interviewed more than 700 primary care doctors and obstetricians and gynecologists. And to my horror, we are not very nice. So we have to educate ourselves because among obstetricians and gynecologists, there was still a very high intention to discriminate. And this is something that we have to tackle actively among our specialty. And so even among the cancer specialists, we've come out with a 13-page document to address the myths and misconception of HPV and cervical cancer. Now, in terms of self-sampling, this really has been a major game changer for us in Malaysia. Many people asked whether Muslim women were accepting of a swab, a low vaginal swab. And really in our community and when we go for outreach programs, there's no issues at all with women performing their own self-sampling. So this is something that can scale cervical screening, I believe, in the lower middle income setting because it removes the need for a healthcare professional to take a sample. And self-sampling is no longer a research tool. It has been shown to be as accurate as a physician-acquired sample. And therefore, in some places, high-income settings, such as in Australia, women are given a choice to either perform the swab themselves or they can have a healthcare professional take the swab for them. The idea here is to allow women to have the choice, to let them decide whether they want to do it themselves or ask someone to help them take a sample. And so the World Health Organization has recommended self-sampling HPV testing as a modality for effective cervical cancer screening. And we undertake community screenings via local champions. If I walk into any community where they don't know me, they are not going to take a screening themselves. And we know this very well from women living with HIV. They want someone they know, they're comfortable with, they trust, without any external doctors coming in to tell them what to do. And so we believe cervical screening can be done by the own community of women who are living with HIV, and they can be supported in a very safe manner. So we've done this in worship places. All you need is to bring a swab and a mobile phone as a quiet place for them to undertake their own screening. We've done this in remote settings whereby the indigenous population have performed their own screening test. And the third and most important thing is also a validated HPV test. I think COVID showed us that so many different types of unvalidated tests can come into a market when there's demand for it. And so for HPV testing, we know that it's the gold standard now instead of Pap test. This has been shown with grade 1 evidence since 2013. Why is that so? If a woman has one opportunity in their lifetime to be screened, and I think this is relevant in low-income setting, if you have one opportunity to screen, doing a Pap smear, you will miss 5 women with high-grade disease. But if you use HPV testing, you will only miss 1, meaning that this test is 90% sensitive in picking up high-grade disease and cancer. But the test that we're talking about has to be validated, and this is very sobering in that more than 90% of HPV tests does not fall into the standards that's accepted by the professional community. 81% of these do not have clinical evaluation, and 60% of this have not even had a single peer-reviewed publication. And so with more than 900 HPV tests in the market, our plea is to ensure that clinicians and healthcare professionals order the correct test. This leads me to the third component of Program ROSE, which is follow-up. I always say this, if you don't follow up any abnormal screening, you might as well throw the screening test into a drain. Because if we don't address a positive test, there's no point in screening. This factor with women is extremely important. We need to acknowledge that they're anxious. We need to acknowledge that they're worried about the financial implications and perhaps the stigma. And so the very important component of Program ROSE is linkage of care. We have a contact center whereby we have a real person, not a bot, a real person who can address women with positive screens. And the foundation and part of Program ROSE is to ensure that the women are led to the colposcopy clinic or for follow-up using to a nearby hospital that they're familiar with. But careful thought needs to be given to linkage of care. It's not just dishing a letter, because we know that if we just dish out a letter, they are very unlikely to turn up at the colposcopy clinic. So when we educate our obstetrician and gynecologists, we as part of the team in ROSE will ensure that the doctors themselves and the healthcare providers understands and pay attention to the ease of women making appointments. And we have also, as part of our program, understood that in Malaysia, women will not pick up phone calls if it's made by a regular line or mobile phone number because they're very afraid of scammers. So we now communicate with patients using WhatsApp. They can read it and then they can decide whether they want to respond from us. And just through that simple intervention, we have found that we are able to increase our follow-up rate by more than 50%, changing our platform from mobile, from SMS to WhatsApp. There's still lots of gaps and challenges and lessons that are being learned, and we can take steps to incorporate into our program. And so these are being taken actively, and we also want to integrate cervical screening to other programs whereby there are touch points with women. So Program ROSE has now screened more than 29,000, and the follow-up rates are about 88%. And if you look at our country coverage, these are very small words, but depending on the population we reach, the invalid swab rates and the positive rates are also different. And so as we get these data on board, we know what to pay attention to. For example, in Sabah and Sarawak, where there's a higher indigenous population and lower literacy rate, the invalid swabs are twice or 3 times the amount in Kuala Lumpur. So these are the things that we need to deal with as we screen more women and as we reach out to areas that are deeper in with less access to healthcare. So we now know our impact because our registry allows us to screen, to follow up, and to measure impact on a live platform. And so with this, we want to remember, this was a photo I took when we were in a community event, the child wearing a cap saying, "I can go anywhere," because the mom is safe from cervical cancer. So if that's the end, and if you want to find out more, Rose uses lots of, or we try to use as many social media platforms as possible to engage with women, to engage with healthcare professionals. Thank you very much.